All right, here we go. Module 5 on depressive disorders and, of course, bipolar. So, one thing I want you to keep in mind is if we start to feel overwhelmed, it's because it is really overwhelming. All the criteria for all the disorders not meant to be memorized. Really, what we're going for with really any diagnosis is familiarizing ourselves. So, oftentimes when we're diagnosing, we're ruling out, right? Like we just are like, well, gosh, that I don't know. I'm going to write that down, but it doesn't meet the criteria for hadn't happened long enough. So just know that if it's like, how will I ever tell these apart? Some of them you will be able to tell apart. Some of them it's going to just be fleshing out. So typically when we're needing the diagnosis is, for insurance purposes, to get approval for services, inpatient and outpatient services, again, insurance approval. So that's when we will be asked, hey, is there a diagnosis? 9 times out of 10, we need one. We'll be talking a little bit more about that. So if you have any questions, obviously I can't see all of you all. Just say, hey, Professor Vite. And I'm going to go ahead and pull up the 1 million slide. Oops. All right. What's going on here? All right. Ooh. Okay. Well, move us all the way over. So again, I don't know how we got that far. Okay. Clinical descriptions and epidemiology of mood disorders. So mood disorders, two broad types, involves only depressive symptoms and then involves manic symptoms or bipolar disorders. DSM-5 TR depressive disorders, we have 4. Okay, we're going to be fleshing those out, but we have MDD, persistent depressive disorder, premenstrual dysphoric disorder, and disruptive mood dysregulation disorder. Now, you'll see that the second two have the same acronyms, PDD. So that's going to be an example of you're probably going to want to write down the diagnosis in full because, or really with any of them, but just knowing like shorthand, if we're doing notes, we might want to write them down so that we don't get them confused because the symptoms look different. Bipolar disorders, we have bipolar 1, 2, and cyclothymia, and we're going to be fleshing those out. So the overview of the DSM mood disorders. I really like this chart. Okay, I think it does a great job of just here's the diagnosis, here's the major features of the diagnosis. Let's see if I can minimize. Okay, perfect. I can only see I can't even see myself. That's kind of good. Therefore, I can't see you, remember, so raise your hand. But the mood disorders down the left side, major depressive disorder, major features. So here we go. 5 or more depressive symptoms, including a sad mood or loss of pleasure for 2 weeks, persistent depressive disorder, low mood, and at least 2 other symptoms of depression at least half of the time for 2 years. Okay, persistent 2 years. Premenstrual dysphoric disorder, mood symptoms in the week before the period. Okay, so I'm going to ask Cal to remind me to talk a little bit more about it. I want to stay on the roll. So if I get an hour in, be like, hey, you're an hour in, don't forget about this because I want to talk a little bit about it. Disruptive mood dysregulation disorder, severe recurrent temper outbursts, and persistent negative mood for at least 1 year, beginning before age 10. Okay, so we don't have childhood bipolar disorder. Okay, so sometimes this can be is it bipolar disorder for kids? It is not. It is disruptive mood dysregulation disorder. I'm going to keep talking a little bit more. Bipolar 1, at least 1 manic episode in your lifetime. Bipolar 2, 1 hypomanic episode and one major depressive episode, okay, in a lifetime. Cyclothymia, recurrent mood changes from high to low for at least 2 years without hypomanic or depressive episodes. Okay, lots more about these, but this is just kind of save this slide. Okay, like save this slide for the quiz. Da da da. I'm going to be using these for an example. So, and again, not necessarily to memorize, but familiarize. Okay. Criteria for major depressive disorder: sad mood or loss of
Oh,
interest. Yeah.
Professor Bright, I just had one
Yeah.
quick question about so we're gonna go a little bit more into the bipolars and the cyclothymia and on other slides you said later on.
Yes. Yep.
Awesome, thank
Absolutely. B part two. Um, so sad mood or loss of interest, those symptoms are present nearly every day, most of the day for at least 2 weeks. So we have nearly every day, most of the day for 2 weeks. The symptoms are distinct and more severe than a normative response to significant loss. Okay. So we have to factor in grief. Okay. And this is where it is one of those things where we talk a little bit further about, have you had a major loss, a major traumatic event? Because that can be PTSD. Okay. That could be grief. So don't get lost in the weeds. We're just trying to flesh it out. It's worth noticing if we just lost somebody we really love. Major depressive disorder, plus 4 of the following symptoms. Okay, so there are 7 symptoms listed. In order to diagnose, you need at least 4. A lot of times, I will just go over the inventory. Just to, has your sleep increased or decreased? Some psychomotor, um, uh, maybe slowing down or agitation, changes in appetite, kind of a loss of energy, that self esteem when it comes to worthiness, trouble concentrating. Sometimes they're like brain fog. Sometimes they're just like, I can't make a decision if my life depended on it. Reoccurrent thoughts of death or suicide. Okay, so we need 4 of those. 4 or more, we can start forming a diagnosis. So continued, episodic, they tend to dissipate over time. Okay, recurrent. Once depression occurs, future episodes are likely. Okay, the average number being 4. Subclinical depression, sadness plus 3 other symptoms for 10 days. Significant impairments in functioning, even though the full diagnostic criteria are not met. So you're like, oh gosh, oh, is it, I'm looking at recurrent, um, are the episodes dissipating over time? Um, Again, a lot of times we're just making our best educated, I don't want to say guess, but it could be inconclusive. We may have to do a little bit more digging, kind of, again, does your laying in bed all day, not being able to go out of bed all day, does that kind of deplete your energy? Well, that'd be 2 symptoms. So somebody might be like, I don't really know about my energy level. Have you noticed that? Lack of appetite, again, might just be contributing to your energy as well. Persistent depressive disorder. Okay, so this is, I want you to think children. Okay, depressed mood for at least 2 years. Okay, 1 year for children and adolescents. Okay, so PDD, we can assign it to both um, um, children and adolescents, plus 2 other symptoms. So we have 5 here. The symptoms don't clear for more than 2 months at a time. Bipolar disorders are not present. Okay, so we don't have like a manic episode or a hypomanic episode. So a lot of times you're using like drop down boxes. Maybe you're at the inpatient hospital and it's like pick all that apply, and you're going, yep, 2 weeks they reported Yeah, for at least 4 days. I'm going to click, yep, that symptom, that symptom, that symptom, and that symptom. And yep, no, 2 months. They still have them. No mania present, no hypomania. It does not do bipolar disorder. As you can see, we're asking individuals to come up with or think through or remember lengths of time. This can stress people out. I'm not sure if it was 2 months or four. That's okay. That's okay. We're going to do our best to maybe think of some examples over those 2 weeks. A question that came up was, let's say they're like, well, 3 months ago, I felt hopeless, but just for a week. And then for 12 weeks, I had really low self esteem. And for 5 weeks, I don't know how well I was sleeping. And then I think I've had a poor appetite. You want to check them. Okay. Because again, if sleeping way too much is kind of taking precedent, you might not be noticing your appetite, but you've said your appetite was decreased a few weeks ago. Totally subjective. Okay, so this is the client reporting, or oftentimes parent or caregiver. So that's when it's just like, or someone's partner. They've observed them for that long, or they've gotten feedback from the school or what have you. Criteria for premenstrual dysphoric disorder. Callie, you're off the hook. Here it is. I forgot that we're going to go into it. In most menstrual cycles during the past year, so our look back as a year, okay, at least 5 or more of the following symptoms, there are like 12 here, were present in the final week before menstruation. And those symptoms improve within a few days of menstruation. Okay. So again, it's like, I know that for 12 months, the 7 to 10 days before my menstrual cycle, so that means they menstruate, and they know that these 7 days, they're irritable, they have higher anxiety, they are lethargic, they lack energy, um, extremely overwhelmed, cannot seem to get out of bed. They're sleeping a lot. Their mood goes down. They're kind of feeling a little bit more hopeless, self-esteem. We're just checking off criteria. They've already said, yeah, for a while now, I can remember that week before my period, I feel this way. I start my period and I feel a little bit lighter. So we see kind of like right here, hormones are introduced or released, what have you, and we start to feel better. These symptoms are relieved. Interesting thing is, well, our women's health, okay, and this is you are born a female, okay, and you are going, adolescence, you start your period, that kind of thing. And you're able to measure. We're going to talk, hang on. One thing we've seen is SSRIs are prescribed on day one of feeling like, whoa, here it comes. You take that SSRI until the period ends. Day one of PMS, the last day of your menstrual cycle, you stop the medication. Prozac, 20 milligrams. This blew my mind because very rarely do you say, take it for 10 days and the other 20 days of the month, don't take it, right? We're like, what? But the combination with the SSRI and what's happening during the PMS make a beautiful release of symptoms. Okay. If somebody is going through a transition and we have an increase of maybe hormones or decrease of testosterone, this can look a little bit different until it's regulated. So it's something we watch out for. But if we are having higher levels of hormones, put into our system, in order to start menstruating, or a decrease, we must stop menstruating. it's hard to assess. So we really want to get that time measurement. Okay, so we're looking at the past year. Somebody says, I've increased my hormone injections and I'm just feeling this and this and this. When did you increase them? Last month. Okay, let's keep an eye on it. Okay, but if you're going to increase next month and stabilize with that, then let's get a measurement, because in order to qualify for or be diagnosed with PDD, premenstrual dysphoric disorder, we want to be very clear about that. We need to measure time. Okay. And 5 of the following of those 12 symptoms. Disruptive mood dysregulation disorder. Okay. Severe recurrent temper outbursts, verbal or behavioral expressions, out of proportionate in intensity or the duration to provocation. The outbursts are inconsistent with developmental level. Okay. You are 12 years old and you are throwing a tantrum. Okay. And, you know, we typically see that by the age of 12, you start to be able to regulate your mood and respond maybe with other interventions. Those temper outbursts tend to occur at least 3 times per week. Negative mood between the temper outbursts most days. Symptoms have to be present for at least 12 months and do not clear for more than 3 months at a time. Here's where we get in the weeds. We're like, wait, 2 days, 3 times, don't get too far. Temper outbursts and negative mood are present in at least 2 settings. Okay, so we're asking, does it happen at home or at school or on the baseball field or when you are socially active, and are severe in at least 1 setting? Happening at school, but we can get it under control. But when we're at home, oh my gosh, all hell breaks loose. And it is the top of the Richter scale in severity. Age 6 or older, okay, or equivalent to developmental level. Here's that onset before the age of 10. There's never been a distinct period lasting more than 1 day during which elevated mood and at least 3 other manic symptoms were present. The behaviors do not exclusively occur during the course of a major depressive disorder and are not better accounted for by another mental disorder. This can coexist with ODD, ADD, intermittent explosive disorder, or bipolar disorder. So again, if somebody is, cannot coexist with the following, okay? Because we're looking at maybe we have a lack of symptoms to meet it. Maybe we're looking at ODD or ADD. So this one to me is a little bit more like, whoa, this is a lot. Okay, this is a lot to diagnose. Oftentimes, we aren't making this diagnosis. Pediatrician will send to get psychological testing or psychiatric testing. Sometimes, it comes in through the hospital and it's diagnosed. So this, it can be maybe, but if you're only seeing someone like weekly, got a lot of work to do with measurements of time. Okay, so this is a deep, deep assessment. Okay. Epidemiology and consequences. Depression is common. We're looking at lifetime prevalence, twice as common in women as in men. 3 times, here's our social work brain coming in, our person and environment, 3 times as common among people in poverty. Okay, lots of other factors playing into decreased mood, increase of symptoms. The prevalence is going to vary across cultures. This is going to really come down to reporting. Okay, if we have 98 individuals from this culture and 98 from this culture doesn't believe in depression, we're not going to report it. No pediatrician or psychiatrist or psychologist or teachers may be going to know because we might not believe in it. MDD, just some interesting statistics about that, about moving to the US from Mexico. have lower rates than individuals of Mexican descent who were born in the United States. I thought that was really interesting. I don't know too much about that other than coming from, having lower rates than those who are of Mexican descent who were born in the US. Okay. A student gave the example, I thought it was really interesting that she is from the Hispanic culture. Um, and, over the years, if you were to tell your parent, aunt, grandparent, like, I'm feeling really low, I'm down, I feel like I'm depressed, that person would respond with, you're just bored. Okay. And I said to her, I said, well, I mean, sometimes we say, like, I wonder if you were to like go on a walk or get a hobby, not going to take the depression away. It might be a distraction. And she was like, no, no, it's very harsh. You go get something that's not going to make you bored, and that's going to be how it's cured. So there's no entertainment of maybe try this or maybe try this. You think you're depressed? You're probably bored. Go figure it out. So symptoms variation across cultures. Looking at these, we can see that there's a lot of physical reporting. Nerves, headache, maybe weakness, poor concentration. I've got brain fog. Those smaller distance from the equator, they have longer day length and higher fish consumption associated with lower rates of MDD. Symptom variation across the lifespan. Sometimes children report, my stomach hurts, I have a headache. In the middle of the day, when I have to do this, like my stomach starts hurting. So a lot of times with kids, our first, point of contact is going to be the pediatrician. Comorbidity, we talked about that, I think in the second class, I can't remember, but 2 out of 3 with MDD will also meet criteria for anxiety disorder at some point. Okay, so 2 out of 3 individuals at some point will have a comorbid diagnosis of depression and anxiety. A chart. Consider this vignette. All right, we've got Kate, 24-year-old individual identifying as female, coming in your agency for the first time, no medical records. She lists her presenting symptoms. So giving us 1, 2, 3, 4. Okay, so there's 4. Hope she can help her feel better. Has been sad, for feeling sad for years, but in the past couple of months has worsened. Okay. Oftentimes when it's lots of crying, wanting to feel better, really sad for years, we give the PHQ-9, which is going to be measuring for suicidal thoughts. Okay. A lot of clinicians just go ahead and give this anyway, especially when have been low for a really long time. I feel like I'm getting lower. So we just talked a little bit different about our approach to assessment and diagnosis. Depending on where you are, you may be required to take an inventory, measurement scales. We're talking about those. Just taking down details. Okay. Might take you a few weeks to take down details, measure time. Hey, client, keep a journal. That way we can start looking at time, jot down all the symptoms. Journaling, as we know, is now in the form of 1 million apps on the phone. Keep this little app on your phone every morning when you wake up. Do this, fill out this. Before you go to bed, fill out that. So lots of different ways to assess, perhaps measure, and then diagnose. Bipolar disorders. Okay, so we have 3 forms, the 1, 2, and cyclothymia. Mania is defining feature of each. Okay, so it's going to be that mania is differentiated by severity and how long it lasts. Usually involves episodes of depression alternating with mania. Okay, the depressive episode is required for bipolar 2, but not for bipolar 1. This kind of is like blows my mind every time I read that out loud, because it's kind of like, wait, all right. If bipolar 2 is less severe, why do we have a depressed episode requirement, but not bipolar 1? I don't know the answer to that, but that's the required episodic symptom or criteria. Mania, a state of intense elation or irritability. Hypomania, okay, under, hyper is above. So hypomania, symptoms of mania, but less intense. The hypo, less intense. So it's under the magnitude of mania. Does not involve significant impairment, but mania does. Okay, gonna be talking about that. Why is this not working? I want to get it all on here. Okay. Abnormally increased activity and energy. Okay. At least 3 of the following are noticeably changed from the baseline. 4 if the mood is irritable. And you're like, gosh, 3 of the following, and then we add irritability. That's 4. Stay with me. And again, we've got 7 here. Looking at mania, we oftentimes hearing like you don't need as much sleep. You're you're talking rapid speech. Maybe that you are very, have a high self-esteem. You might believe that you have special talents, powers. We're going to be talking about this, what kind of powers or abilities. Your distractibility can be present, attention easily diverted, excessive involvement in activities that are likely to have undesirable consequences. So, a big one here, such as reckless spending, sexual behavior, or driving. Typically, driving at a very fast speed. I reach a state of euphoria. I go 90 down I-65 on my way to Alabama. Okay. Our trauma-informed language would be, okay, how do you think that you're putting others or yourself at risk? Yeah, we're thinking, I bet they'll say maybe they could run off the road, hit somebody. I don't know. It just feels really, really good. Okay, do that for a couple of days. Reckless spending, this might be occurring debt really quickly. Like in 4 days, you have maxed out the credit card. Okay. If that's not something that is typically what you do or what you can manage or handle, that is considered reckless spending. This is a little bit subjective in nature because this is going to be based on you max out your credit card. Can you pay it off every month? Are you buying and buying and buying and you have stuff all over your house? You can get into a little bit of what do you do with it? Sexual behavior. So again, a little bit subjective with sexual behavior because you may need to know them before they have a manic episode. So if you know they have a high libido, they like to engage in sex, and they are super careful, just making sure they stay safe. If it is an increased need during this episode and we are seeking out uh, sexual experiences that put ourselves at risk of maybe of being sexually assaulted, or we add drinking to it, where we do not remember what we're doing, then that could be harmful, and have a consequence that perhaps you weren't thinking about in that manic episode. Okay, so that's going to take like maybe knowing them or having them report, like there's just 1 week during a month. I mean, I just go on a bender. I want sex. I crave it. I seek it out. I get it. Okay. Have you ever been in a situation where you felt threatened or it felt out of control? So trying not to lead them, but really asking, has there been anything that's happened as a result of that sex spree, if you will? that has been an undesirable consequence. For a manic episode, 1 week. Okay, these have to be present for 1 week. The symptoms can cause distress or functional impairment. Okay. So for 1 week, we've got this going on, but it's really it's really distressing, or it impairs our functioning. We cannot go to work. We have trouble parenting. And that's really distressing when we need to be doing that. But we are up here having a manic episode, hypo. So underneath that, symptoms lasting 4 days, clear changes in functioning that are observable to others, but impairment is not marked. Okay, so less severe. Okay, no psychotic symptoms are present. We haven't had a hallucination or a delusion. Again, 4 days. And oftentimes we will say, has anybody noticed a change in your behavior? My mom says that, like, I just, when I get all dialed up, like, I just have a lot of talkativeness. I talk a lot, but sometimes I'm not this talkative. Okay. My mom is really worried because I have a huge decreased need for sleep. I can go for 72 hours, not sleep a wink. I'm not tired the next day. Okay. Really great when we can have somebody else observe what's going on, because we're just kind of like, thank you for letting me know, what that person observed. This is helping me help you. Criteria for bipolar disorder. So we just went over that. But again, one episode in the lifetime. Mania for bipolar 1, bipolar 2, kind of doubling down on the other one. Major depressive episode with one hypomanic episode. So, cyclothymia or cyclothymic disorder, going to be milder, a chronic form of bipolar disorder, lasting 2 years in adults and 1 year in children and adolescents. So here's that time frame. Someone comes in and says, I think I've been feeling really sad, really low for 5 years. Numerous periods of hypomanic and depressive symptoms. Okay, so, all right, do you know when those occurred? I don't. I just know that every now and then for 4 days, I'm feeling this. Every now and then for 5 days, I'm feeling lower. Cyclothymia is a diagnosis given when we don't meet criteria for mania or major depressive disorder. Symptoms don't clear for more than 2 months at a time. For the past 2 months, I literally have felt just this way or this way. Symptoms cause significant distress or impairment. Okay, so it's one of those things where, like, gosh, is it cyclothymic or is it bipolar? Okay, we're just kind of fleshing out a lot of it. The commonality of these is going to be pharmacological intervention. Okay, so if you have 7 days of mania and then this person has 4 days of mania, oftentimes a mood stabilizer of varying milligrams is going to be prescribed. Same with cyclothymic disorder. So a lot of times it's like, oh gosh, how do I can't tell what it is. Well, if somebody is, talking about a really long time, they mention these manic, hypomanic episodes off and on, 2 years, 2 weeks. Again, we're jotting down criteria. Oftentimes the prescribing individual, psychiatrist, what have you, is going to be adding or going to be looking at a mood stabilizer, such as Lamictal. Lithium for more severe. Talk about that. Prevalence in adults. I feel like I'm reading off here, reading off these slides. They're important, but just kind of giving more statistics. The burden of the illness. Okay, so bipolar disorder is the 6th leading cause of a disability, according to the World Health Organization. Okay, bipolar disorder in youth, not children, Again, impaired family and peer relationships. We are looking at academic performance, perhaps psychosis, those disruptive behaviors that we're trying to rule out. Is it ODD? Substance use disorders. We're going to use this substance to kind of manage our feelings or lack thereof. We've got medical problems that can be associated with it, frequent hospitalizations, suicide attempts, and then the completion of suicide. The burden is really heavy. Okay, it can be really heavy the older you get and not being treated. Okay, so again, it's like, okay, for the past 7 years, that's a long time to have a lack of support. That's a long time to have on and off psychosis, long time to be using drugs and alcohol to treat some of the symptoms. Okay. That can, again, lead to frequent hospitalizations, suicide attempts, or completion. Age of onset and course. So again, just looking at the progression. Not going to read those to you because we have it right here. Clinical presentation. Okay, so just if it's like, what's the clinical presentation? We're looking for episodes. We're looking for elation and then that grandiosity, that high self-esteem. I've got powers. I can do anything. Got the irritability. We're also kind of looking at, is it depression? Could it be ODD? Bipolar depression, the most common manifestation, increased risk for suicide. Okay, so again, that depression, length of time. Do you feel really low, really bad, really blue, really sad for a long period of time? That's going to increase that risk that you don't want to live anymore with that diagnosis, disorder, criteria, symptoms, what have you. So worst outcome is going to be associated with these, right? And here is where person and environment fit. So what we're looking at is the low socioeconomic status, exposure to negative life events. So this is looking at, again, the poverty. If you cannot afford testing early on for ADD or behavior problems, you can't be treated. If you have a constant exposure to negative life events, I'd say trauma, just witnessing, experiencing, don't process it. That is that social work perspective that we're looking at. We're in a hospital setting and it's like, they've had this and they've had that, happened when they were 5. We're saying, oh, is that early age due to how they were or how their environment was? Or have they had trauma after trauma? Has anybody asked them, like, have you experienced frequent loss of individuals? Has a parent died by suicide? Have you had just a lot of loss? Have you jumped around from schools because of you needed to move? What have you? Jumping around from schools does not mean you're going to be diagnosed with something, but just adding to lots of change, some of it pleasant, perhaps if it's non-pleasant. Epidemiology and consequences. Again, we're talking about prevalence. Average age is in the 20s. No gender differences in rates of bipolar disorders, but we know that women experience more depressive episodes, severe mental illness. A third of those unemployed a year after hospitalization. We're in for 2 weeks, out for 3 months, in for 2 weeks, out for 4 months of work. Keeping your job, it's going to be a challenge. Okay. Losing a job, going into hospital, losing relationships, going back to the hospital. all the things that can make us feel hopeless and helpless, which is why the suicide rate risk increases. I like this table here. Not going to read off it, but just the subtypes. So we have the subtype. Is it applicable to major depressive disorder? Is it applicable to bipolar disorder? And then the definition. So I really like, like rapid cycling, manic, depressed, applicable to major depressive disorder? No, but yes to bipolar disorder. Okay. So I like the way that that kind of is spelled out in, there are some overlaps with both of them, and then are some no's for the applicability to mood disorder. Charts. Interesting stuff. Going to be the research behind it. It's beautiful. Hyperthymia or hypothymic temperament, not identified in the DSM. Okay. An exaggeration of the level of mood, non-cycling hypomania, so the 4 days, frequent, consistent state of energy, activity, and confidence, often with irritability and distractibility. These characteristics are generally admired in Western society. How hard we work, right? The grind, lack of self-care, can be, again, that type of behavior, okay, could be appreciated. Working really, all the things, working overtime, high success, all of the things that we appreciate in our Western society, but can affect our overall mood, generally not associated with severe mood swings. So probably if you're at a hospital and you're doing the assessment, hypothymic temperament might not be listed. It might just be inconclusive. Okay, so since this isn't a diagnosis, it's not going to be on there. Inconclusive, need more evidence. A lot of times hospitals will say this meets criteria for admittance, even though we have an incomplete diagnosis, because we're going to have to see somebody for 4 days to see what's going on, or 5 days, or introduce medication to see what symptoms are relieved. Chart. Etiology of mood disorders. Okay. What factors contribute? Neurobiological factors, psychosocial factors. Okay, so neurobiological, and then again, we're looking at the psychosocial factors. Other disciplines do as well, but we definitely advocate for those psychosocial factors. Neurobiological, we've got the genetic factors. We also have like a specific gene, okay, that's going to influence the dopamine function that is related to MDD. So here's where we look at a specific gene, influence the dopamine function that's going to increase the diagnosis of or related to MDD. Again, I like this. I'm not going to go over, but there's the neurological hypothesis, major depression, and we're going to be looking at the influences of, moderate, it's present or lower, sometimes higher. I like these types of charts a little bit better. Etiology of mood disorders, the neurobiological. Here's where we're getting to those neurotransmitters, or norepinephrine, dopamine, and serotonin. Okay. So the original models, okay, for measurement are going to focus on the levels of neurotransmitters. MDD, low levels of norepinephrine, dopamine, and serotonin. Okay, major depressive disorder. Mania, the higher levels of norepinephrine and dopamine, lower levels of serotonin. So there's an overlap there, the lower levels of serotonin, okay, but high and low vary with norepinephrine and dopamine. Medication alters, we talked about this in module 2. Can't remember, but it alters the level immediately, but we might not see relief from 2 to 3 weeks. So while it's going to maybe change the dopamine receptor, medications in the system, we just might not see relief. So something oftentimes when we're talking about medication, tomorrow, I want to see relief tomorrow. It's so bad I want to see relief tomorrow. Absolutely, you do. However, it's common that it's absolutely working right away, but it's going to take 2 to 3 weeks to notice it working. The models of the focusing on sensitivity of postsynaptic receptors. The dopamine receptors might be overly sensitive in bipolar disorder, lack sensitivity in MDD. Depleting tryptophan, I'm not sure how you say that, precursor of serotonin, causes depressive symptoms in individuals with personal or family history of depression. Those who are vulnerable to depression may have less sensitive serotonin receptors. Okay. Again, not needing to memorize, but here's just more of those neurotransmitters. The brain, beautiful, beautiful. Okay, so we're just, again, the activity of brain structures involved in emotion responses among people with mood disorders. So here we have, again, the brain structure level, depression versus mania. Okay, so we're being asked about the brain. We have brain imaging, sometimes covered by insurance, sometimes not. Just going to be looking at it a little closer. Those functional activation studies focusing on the activity levels. Brain, skipping through. Etiology of mood disorders, neuroendocrine system, okay? Overactivity of the HPA axis. Here we get into the cortisol release, our stress hormones, and there's that amygdala, an overreactive amygdala. So findings, research tells us that findings that link depression to high cortisol levels. So here we have Cushing's syndrome, the diagnosis of Cushing's syndrome's the oversecretion of cortisol, symptoms including those of depression. The injection of cortisol in animals, okay, is how we were testing it, producing depressive symptoms. Dexamethasone suppression test, lack of cortisol suppression in individuals with a history of depression. Okay, so this is the etiology. I've not really been asked too much. Every now and then we do. You can use this slide if you'd like. Social factors, life events, interpersonal difficulties, behavior of depressed people, often leading to rejection by others. Okay, so what happened? Let's look back. Is there major breakup, loss of job? Did you lose a loved one? That lack of social support. I have nobody helping me through it. I can't talk to anybody. That's a stressor, right? Interpersonal difficulties might be relational. High levels of expressed emotion by family members predict a relapse. Behavior of depressed people, that rejection piece, needing a lot of reassurance, a lot of self-disclosure around what people might call negative, but always having something. They always have something. The slower speech, longer responses. So here's how I sort of reframe this. I've noticed that I need a lot of reassurance. I just don't feel confident. I don't feel like I'm doing a good job. I don't feel like my paper is well written. And I just feel bad about myself. And I really feed off of validation that I'm doing a good job. And lately, and sometimes what I'll say is when they say people are just distancing from me, and I'll say, how many people have you told about what's going on and in what settings. Um, Now, people might be annoyed with them. Like we hear the same story. Something is always wrong. Something is not going well. Same song and dance, different day. I will say, I wonder if people kind of, hey, how's it going? And they keep on going. I wonder if it's because they don't know how to respond. And that can be true. If someone's constantly telling you something and the person's just like, I don't know what to say, oh, that stinks, we don't know what to say, right? That can happen with, partners or spouses or children, that kind of pull away from their parents because they don't know how to care for them very well. That can, increase the depression. Etiology of mood disorder. Okay. Psychological factors. So here we have the cognitive therapies. We've got Beck, right? That the view of yourself, your world, your future, the here and now situations, kind of an overall negative schema outlook view of it. We can have cognitive biases, the tendency to just process information in negative ways. Um, it's never worked before. It's never going to work again. It failed me that time. Never going to work again. Just the world's out to get me. The future's going to be really dark, because I can't A, B, or C. Can't do this, can't do that. Hopelessness theory, the most important trigger of depression is hopelessness. The desired outcomes won't occur. An individual has no ability to change the situation. I cannot leave this marriage, cannot leave this job, cannot take a break from my kids, cannot stop caring for my elderly mother with dementia. Okay. That's a lot. And sometimes as clinician, it's really hard because we're looking for, gosh, I hope maybe something changes. Maybe they'll get a job they like. Maybe they'll end up getting a divorce. That's some big changes that have to be made. Stable and global attributions can cause hopelessness. Also looking at, we do notice higher levels of anxiety around election time. Okay. Maybe just a decrease of mood, not really diagnosing anything, but if someone's coming into office and you are going to have this policy taken away or put into place that's going to affect your living situation, your benefits, etc., that could be really stressful to be wondering about, how is it going to affect me? How's this election, this official going to affect kind of my daily living? You all have seen the negative schema, the cognitive of biases, in many forms of fashion, but kind of this lean towards CBT. The negative triad, again, negative views about the world, about the future, and then about oneself. This is so bad. This isn't changing. I can't change it. There's nothing I can do to change it. I'm gonna go in that little pyramid where one kind of influences another. Hopelessness theory, talked a little bit about that, where that a negative life event can take place. The overall lack of change, increase of hopelessness. This is really hard. We have clients that are completely hopeless. It's not that I get annoyed. I just find it extra challenging to find solutions. If it's like, have you tried this? Have you tried that? Have you tried this? That'll never work. Nothing has ever worked. Sometimes I'll push back a little bit and, how long did you try sitting on the edge of your bed? We talked about for 2 weeks, just trying to get to the edge of your bed and get to the shower. I did it for 2 days. It didn't work. Okay. How about like calling a friend you said would is makes you comfortable and makes you laugh? You know, we kind of talked about like touching base with them. I haven't done that. Now, we're not shaming anybody, but we're kind of going, oh, last week we were just kind of talking about ways to just alleviate a little bit of the hopelessness, which makes you feel helpless. But that is where we are sometimes working harder than our clients are, which we know can happen at times. Um, Example of the attributions. Okay, all of these things equal lack of intelligence. Okay, so global, stable, unstable, lack of intelligence, I'm tired or exhausted. The specific reason I failed is the mathematical portion of it. I'm fed up with math. Well, gonna have to do the math portion of the GRE typically, but just kind of contributing to, you know, the overall state of how you feel. Life events interact with serotonin. Okay, so again, we are looking at the changes in serotonin related to maybe trauma. Okay. And what can happen with our neurotransmitters when we are experiencing trauma. Okay, it's not genetic, like, you know, overall, like life is fine. Okay, but like 3 months ago, my mom completed suicide, and I've been having to take care of everybody, and I haven't had a chance to grieve. And I just noticed that the number of things that keep happening to me just going to take a toll. Okay. So those are self-reported depression symptoms. Um, that again, an individual, you know, we're not kind of going down the life events, but a lot of times people discount but the reason they're feeling so bad, I should be coping. I should be through with my grief because they have some sort of idea about where they should be, how they should have reacted, and how they should be feeling. Okay. Social and psychological factors in bipolar disorder can trigger a depressed episode in bipolar disorder, appears similar to the triggers for major depressive disorder. So here we have the life events, negative cognitions, all the things, predictors of mania, reward sensitivity, sleep disruption. We you know, our sleep is disrupted for a number of days. For 5 days, we've stayed awake, maybe not necessarily by choice, but by disruption. We are starting to increase mood a little bit. I am going to stop sharing right here. Might have heard my husband just getting water. So any questions so far? Any questions or comments?
So, Professor Brett, that last graphic, that one word, I'm sorry, can you remind me what that like term was? It was like, um, I didn't write it down. Sorry.
Mm.
God, no.
I'm going backwards.
Oh, here we go. LA. Sorry.
I'm gonna have to Google how to explain that.
Okay.
It's in my
Yeah, I've
head.
never seen that word before. It was interesting. I was like, oh, some LDO or something. I don't know. Interesting.
I'm gonna put somebody on the Google. I'll mess that up because I think I know, but now I'm like, I don't know if that's
What are we Googling?
um allele, allele.
Alleles are part of your chromosomes. They're the different legs on the chromosome that you pass from parent to parent. So you have a long allele and a short allele on your chromosomes, and that's where your
Oh.
DNA is coded. And so when it splits and you get half from a parent, half from the other, those are the alleles that you're getting.
Oh, right on.
Thank
Thank you
you.
for explaining that.
Dang. Thank you, Cal. Cal coming through.
I was originally a biochem major in college.
We're going to count on her then.
Smarter than I.
Count on Cal. Other questions? Are you kind of feeling like, whoa, how do I distinguish one from the other? How do I measure one from the other? This seems all overwhelming. I'm not like, you're overwhelmed, but does it feel a little overwhelming? Good. Hope. It's a lot for sure. Lot to take in. I'm chewing. Just took in a lot of pizza. But the goal again is to familiarize yourself, not to memorize, but you'll start to be able to kind of say, that sounds like a manic episode. Now I'm going to ask, how long? What behaviors were present? To start to then say, bipolar 1, bipolar 2. Once again, the pharmacological treatment for bipolar 1 and 2, cyclothymia, typically looks a little bit similar. Maybe it's a low level of Lamictal, low level of Prozac, depending on like the milder symptoms. Okay, so we're kind of trying to stabilize mood stabilizer, and relieve the feelings of depression by just having like we hear a lot about cocktails, like this goes well together, and you can do like a lower amount of each one. So sometimes that's why it's like they're prescribed 2 things, well, trying to just do lower amounts of each to kind of prevent going up to 300. Not a problem, not bad to prevent it. Just trying to perhaps lower the what am I looking for? It'll come to me. Hope. Is rumination found in other diagnoses? Absolutely. Absolutely. That being said, what other diagnoses do you think could have rumination? Anxiety, right? None of that. OCD, eating disorders. Okay, kind of ruminating on how much I eat, how little I eat, how often, etc., and just really kind of fixating on all of those factors that could possibly, not always, contribute to an eating disorder. So possible, but not always. But just looking at how's it affecting your day-to-day life, having to make choices all day, having to navigate something all day long, making those, let me sit and think on it. How's this going to affect this and that? What will it do for this? What will it do for that? Good question. Righty. Treatment of mood disorders. There we go. So bipolar disorder assessment, the assess find of mood disorders. So this is something just to keep in mind. So know this for the quiz. We're looking for frequency. Okay. How long has it lasted? Intensity. Is it getting worse? It's more severe. The number of episodes or criteria or symptoms. Okay. Oh, that's 4 out of 5 symptoms. Okay. How long it has lasted. Only 4 days. Oh no, they said 7. Okay, so those are kind of what we're taking into account. Psychiatric interviews, again, some people use a lot of measurement scales, clinical based rating scales, youth, parent, teacher, not always a coach. Maybe we are like, oh, this is how they, present when they don't do well. That's not going to be typically. Someone was asking about that. What about the coach? They'd have to see him for a good amount of time all day. So just taking inventory of different environments where the behavior overlaps, okay, with symptoms. Like I said before, like that timeline, okay, I don't know how long it is. All right, let's take like some time to like write it down. Let's measure it with this app. That could take weeks, sure, but you come back next week. Let's just look at every day. This app says to do a morning check-in and a bedtime check-in. It's just going to be helping inventory. At the end of the week, it's not going to spit out, you have blah, 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 blah. It's just to kind of keep up with frequency, intensity, number of symptoms or criteria, how long it's lasted, known as duration. Other areas for assessment, the psychosocial functioning, caregivers, partners, spouses, friends, coworkers, teachers, how is all of this influencing criteria, report of criteria, the level of care, kind of coming down to intensity, okay, and restrictive type behavior. The mood symptoms are really severe, okay? We're talking more and more about suicidal or homicidal ideations. We have psychosis. Perhaps we become dependent on substances. Overall adherence to maybe medication, maybe the family environment. So that might be assessing the overall safety of an individual. And then the level of care, again, we're talking higher, might be inpatient. Or you know what? I don't know that they need inpatient per se because they're not expressing any suicidal or homicidal thoughts. Maybe everyday outpatient. Substance dependence, again, we're talking dependence. Again, sometimes the level of care is first detox and then treatment. So before we can even do anything, we are looking at what's going to look like to come off the substance. When it comes to mental health, individuals say, can we treat both the substance and the anxiety? Yes. But until the substance is totally removed, we cannot get it sometimes an accurate symptom inventory. Okay. Lots of high anxiety when I black out. Have an anxiety disorder? Maybe you are highly anxious, paranoid, worried about what happened when you don't remember after being on ecstasy for 3 days. Okay. So we're looking at the substance. How long was it in your system? How often do you use it? If you come off that substance, will you need a detox unit? Okay. And then medical conditions, measuring thyroid functioning and how that is influencing mood, depression, all the things. Take a whole blood count. So a lot of times we're just ruling out like medical disorders, B12, folate, and iron levels. Around Nashville, kind of the city, I'm seeing more like serotonin centers, and I just do quote because I saw serotonin center, 14 shots of B12 for $1,000 or $200, what have you, or stop by this apartment this coming Saturday. This is literally right across the street from me. You get a free B12 shot if you sign up and sit down and listen to it. So that can work, right? Yeah, your B12 levels are a little bit lower. Maybe you need to supplement them. Maybe that's why you're feeling tired, lethargic, not hungry, what have you. It's if the course of treatment around that intervention and the symptoms are not getting better, then it might be low, might be okay to get the B12 injections, but if it's not working, then we're not looking at that having an overall effect on mood. Okay. Assessment tools. Okay. The PHQ-2, PHQ-9, geriatric depression scale, lower amount of questions with individuals with mild or moderate dementia. We could overwhelm somebody. Well, can you let us know how you felt last week? I don't really know how I felt last week. Okay, let's start with yesterday. I don't really know how I felt yesterday. We could shut down, we could have some shame. But what I can tell you is 2 years ago when my daughter got married, I've never felt better. That long-term memory recall. It's like, how can they remember 10 years ago, 15 years ago? The memory has been stored in their brain in order to sometimes like kind of don't ask me about yesterday and last week, but I'm going to prove to you that I know what happened 2 years ago. Okay. That is sometimes used when we are seeing an increase of depression comorbid with dementia. And that sometimes, again, they are a little bit, they know it's happening maybe, or it's getting worse. And so while they can't say, I have moderate dementia, wandering around not knowing where you are completely, seeing familiar faces but not recognizing them can be really depressing. Okay. And then, of course, the Beck Depression Inventory. Remind me at the end, somebody remind me at the end of this to tell me, to tell you kind of my impression of assessment tools, and then I want to know yours. If you're seeing an elevated score on the screener or the assessment, just some suggested wording. Today I noticed it was like a little bit higher. Anything specific going on? Today you report this and this with your mood. I wonder if we could talk a little bit about what's going on today. And just overall in the past 2 weeks, how have you been feeling? We know that the depression and anxiety can be comorbid. We might consider giving the assessment tool of the GAD. Okay, so now let's measure kind of anxiety and see where you're at with that, just to see how severe it is. Important to rule out mania and hypomania due to how we can behave, risky behavior, etc. Have you experienced sustained periods of feeling uncharacteristically energetic? Someone's like, what does this mean? You've just noticed that kind of on average, your energy level is just, that's just kind of how you feel, like tired in the afternoon and getting ready for bed and that kind of thing. But this week, these 3 days, your energy level has gone up. Have you noticed periods of not sleeping, but not feeling tired? A lot of times, those of us who may be up for 48 hours studying might feel extremely tired afterwards, really have that crash. Thoughts racing and couldn't be slowed down. Am I a bad person? Am I a good student? Am I a good parent? Am I a good friend? Am I going to make book club? What are my grades going to be like? Racing from one thought to the other, not slowing down to kind of process that thought. Am I a good friend? Oh gosh, did I talk with her last night? Did she notice I was talking with her? Did I seem like I was caring? Racing, but we're kind of, fleshing out those racing thoughts and stick to kind of like one thought. It doesn't mean someone is manic by any means, but it's just something to look for in combination of racing thoughts, stay up all night with my thoughts racing, that sort of thing. Again, here's this like unusual risky behavior, an excessive speed, an excessive spending, excessive sexual interest. Could any of these put you at risk of A, B, or C? Now, here's where I, say, okay, that does sound like, going 90 on the interstate every time. That's over the recommended speed limit. So it could increase your chances of losing control, maybe, what have you, where I just kind of, someone tells me they're drinking and driving and going this speed, I will get a little, impairment of judgment and motor abilities. High speed, weaving in and out at a high speed. How many people, we need to look at your substance use and the risky behavior, because the two hand in hand are definitely going to perhaps impair your reactive time and judgment. Okay. And you could not only hurt yourself, but multiple people, right? With speeding, but add some alcohol, just increases that last. Have these episodes lasted most of the day for at least 4 days? We're looking at hypomania there. They're all day, every day for 8 days. Okay, now we are kind of going to be assessing for mania. Oops. Okay, no, here we go. Formal assessments, again. Some people like to ask an individual these questions, and we just say just yes or no. You don't have to explain it, but yes or no. Some people give this assessment and say, fill this out, take your time. Oftentimes when we are asking them questions, just say yes or no. What does the person want to do? Want to elaborate a little bit? Well, I don't know, they said it was a little bit more talkative, but because I was at book club, I felt like really comfortable. I've been working out a lot lately. Does that count as more active? Kind of unusual, maybe usual. My libido has increased. Yes, so I'm interested in sex a little more than usual because my libido is increased. Has the libido increase and the increase of sexual interest had any consequences that were counterproductive or dangerous, that kind of thing? So that's, again, a lot of these are so subjective to like, well, today I did. That leads me to, I was going to talk about this at the end, but I want to ask you all, how do you feel about using like a formal assessment, meaning, an evidence-based assessment tool, such as what we just talked about? Do you all use them? How do you feel about using them?
I've used them before, and I feel like I'm doing them right just by following the list, like 1 to
Okay.
10, but I'm always like, feels like a little sterile, kind of.
Uh-huh.
The more I do it, I feel like I'll get more confident. I think I did the Beck's anxiety inventory before.
Okay. Thank you. Anybody else have a feeling about it? Maybe you haven't used one yet. What Jacob just described is a good example of feeling a little bit more sterile. We've been talking, we're having a dialogue back and forth. Go ahead.
Yeah, totally. Yeah, I think it was just like me transitioning from like trying to be just like established rapport to like asking those questions a little bit. Um,
Mhm.
I think I could have made a better transition of like, hey, do you mind if we kind of ask these?
Oop, I don't know why I can't hear you. You're not muted. Uh-oh. Can anybody hear Jacob? I can't hear you. Can you hear me? Now you're muted. That was weird. I don't know. That's okay. But I like how you just pointed out that maybe well, now you probably maybe you can't hear me. How you transitioned from kind of the traditional talk therapy to just going into an assessment mode, and maybe your client isn't used to it. So like, what are we doing? Asking permission, just to get a little bit more accurate of a depiction. This symptom inventory is going to just be fleshing it out. Okay. I get nervous because I'm so scared I'm going to be like, they're going to be like, well, just today it was so bad. I got fired and blah, blah, blah. So I'd say it's severe. And I'm like, well, not just today, it's a week. But then we start talking about the job, so sometimes I'm like, wow. I've found that sometimes just if it is a bad day, it is more severe. We do feel hopeless, helpless, very tired. My appetite's gone. I have a headache, low energy. What went on? Did anything happen today that could contribute? So, oh, here comes Jacob back through. Welcome back, Jacob. Welcome to it. Oop. There we go. Okay. I'm going to keep rocking and rolling. Okay. So again, eep. Sorry about that. That was a screening. Okay, here we go. That's the formal assessment, so not a screening. I take that back. This is a formal assessment. It's the MDQ, so it's a questionnaire. We hear a lot of like, we're just going to screen you for such and such. Maybe not as in depth, maybe not as precise in the flesh out. So as you see here, number one has a lot of, here's what I mean by a period of time where you were not your usual self. We ask all of those. If we checked yes to more than one of the above, have several of these ever happened during the same period of time? So we keep kind of fleshing out the details or the symptoms or criteria. Elevated, up, depression, down. To me, my eyes go a little bit, blah. Psychological treatment of mood disorder, IPT, interpersonal psychotherapy, maybe some short-term psychodynamic therapy or focusing on interpersonal relationships. CBT, a lot about that. Mindfulness-based cognitive therapy, strategies, maybe meditation, maybe a little bit of like very light yoga, not like a workout yoga, maybe a sound bath. How are we mindful in our strategies to prevent a relapse? Behavioral activation therapy, an increase in participation in positively reinforced activities, okay, to disrupt the spiral of depression, withdrawal, and avoidance, okay? Can we maybe not watch that horrible, depressing movie? Can we limit our time with so-and-so? Can we meet with our mentor at work a little bit more to get feedback if we feel like we are not doing a great job? And then behavioral couples therapy, enhancing communication and satisfaction. Okay. Your partner really wants to know what is going on and then what to do. Because if we are living with somebody for 2 years, distance can happen, avoidance can happen. If somebody doesn't know how to help somebody and the other person doesn't know how to communicate, we just could have an overall, just a breakdown in the relationship, not necessarily a divorce, but we could find ourselves going, I don't really know how to help or what to do, or how to talk with you without you exploding. So coming up with strategies in order to enhance the relationship, overall satisfaction. The cognitive therapy, thought, monitoring and challenge, examples of the daily thought monitoring, and rating. And then again, we break it down by morning and dinner, and then breakfast, a rating scale, what cognitions are coming up, so on, maybe an example, so on and so forth. If we're going to use one of these, we have to remember that I didn't do it for 3 days. That's okay. Might be harder to get an accurate depiction. I don't know what my automatic negative thoughts are. That's okay, but it's hard to find an alternative thought or view of the situation. So it's not a bad thing if we don't know or we didn't do it. It just might not work as well. Treatment of mood disorders, the psychological treatment of bipolar disorder, psychoeducational, okay, approach, providing information about the symptoms, the course, potential triggers, and treatments. So, for example, somebody is about to leave the psychiatric hospital. You know, we've been here for 11 days. We've been doing group, not tons of stress, right? Like that person at work that's made you angry isn't walking around, you know, kind of triggering you. All right, Katie Vite, you're going back to work, back around these people. You know, what could potential triggers be? What are we going to look out for? What might help you cope? Typically, if somebody is under the age of 18 and they're an inpatient, outpatient, some type of treatment, family member is usually required to be present to bring them back to where they live. And a lot of times it's going to be psychoeducation for those who are with them or experiencing their symptoms, what have you. I have a client, she really likes the mania part of her bipolar disorder. She can teach this many spin classes. She is running around, super energetic. She's funny, firing off on all cylinders, right? Okay. You know, well, didn't get enough sleep, her family will report. You know, on the flip side, like you can be really combative. Your irritability is so high that your kids don't want to be around you. So that's that piece of very fortunate if you have a support system that can recognize some signs and symptoms, try to get you help, encourage you to get help. Not always the case, but a bonus if you are in college, this is going on, your parents, you know, you're an adult, you can be discharged back to UT. Parents come in, let's walk it through, how to help you. Okay. That's a lot of support. It's a privilege to be getting that kind of support. FFT, family focused treatment. Biological treatment, ECT, okay, is going to be reserved for treatment of non-responders. Okay, so we've tried CBT, we've tried all the things, we've tried these medications for this long, and we want to try ECT. If you're wanting insurance to pay for it, oftentimes you have to show how long you took what medication, at what dosage, etc. ECT induces brain seizures and momentary unconsciousness. Could have some memory loss. The unilateral ECT, so the electrodes for unilateral might be up here and here, so just a difference in the placement. Not exactly sure why. I just know that that's a different type of placement. Oftentimes ECT is more effective than medications. Well, if we've done a number of medications, then perhaps it will be more effective. We're really unclear how ECT works because everybody's brain is different. Okay. We know that how it works in the way of just put on the head or inducing brain seizures. So that's how the process works. The after effects, don't always know how it worked on that particular brain. Okay. Hey, symptoms are relieved. We would call that a successful outcome and treatment to symptomology and criteria. TMS, transcranial magnetic stimulation for depression, a little bit less invasive than ECT. Electromagnetic coil placed against the scalp. And you're not going unconscious, okay? Not having a brain seizure. Oftentimes those who do not think I don't like that fail to respond, but don't respond to antidepressants might consider TMS. More and more insurance is recognizing this, but the same as ECT, insurance is going to say, how long did you do the medication? What was the dosage? Who measured the symptoms? We need someone to sign off on that. Typically, the person who's prescribing antidepressants. Not a lot of times do they want impressions from therapists, okay? Every now and then. But we're looking at medication response, not necessarily therapy response. So that's why the prescriber is typically the one that's giving all of the pharmacological interventions that were not successful. Response rate, okay, patients with major depressive, that's 70%. Okay, that's a good amount. With treatment resistance depression, still a good 58%. Indicators or indications, depression with psychotic features. Okay, so ECT is the first line of treatment. Severe depression, catatonia, treatment-resistant depression, older adults, indications, pregnancy that could be inducing different symptoms. Don't think you can, well, I'll have to look that up. Part of me wants to say, I don't know that you could be pregnant and do it, but I'm not sure that inducing a seizure, I don't know. What? I'm going to look that up. The risks, headaches, potential brain fog, sometimes nausea or fatigue, retrograde amnesia, usually temporary. Okay, so start to get our memory back slowly but surely. I had a client that we stopped therapy because she did 16 weeks of ECT, and she had to go every day for insurance to pay for it. She was so tired after it. She took a semester off. We just could not, it just couldn't be treated. Therapy was not helping at all. Medication wasn't helping. Tried different classifications of medication. And when she came back after 16 weeks or so, she didn't recognize me completely, looked familiar. And she had really no working memory of what all we had worked on. Wasn't a bad thing. Part of me was like, well, she's kind of forgotten about it. But chances are that working memory might come back. So it could be a temporary response to memory loss. Okay. Slowly but surely she didn't remember some things, and then some things came back pretty in lots of detail. That's what I'm trying to say. See if I need to go find my charger real quick. So, okay, good on battery. We've got the thing in the mouth for the induced seizure, so someone doesn't bite down, break teeth, crash through tongue, lip. Here are the medications for treating mood disorders. Again, the category of medication for an antidepressant and mood stabilizers, okay, and then the generic name and the trade name, okay. So you notice that lithium is the generic name and the trade name. So we don't have necessarily a generic as of yet for lithium. I'm not sure if we will. Hadn't kept up with that. Biological treatment. Okay, a lot of studies, have overestimated the effectiveness of medication. Treatment alternatives to relieve depression. Lots of different attempts. Again, this has to mean that individuals have reported it. But to evaluate effectiveness of antidepressants in the real world. So let's get you back out there and measure symptom relief. Okay. So this particular study, 3,671, 41 different sites or agencies or hospitals, what have you. 33% achieved full symptom relief with citalopram. That's the SSRI, generic for Celexa. That would have to be you took the dosage during the time frame, you took it every day, and you were reporting back. So if you just stop the treatment, at 2 weeks, you're going to be reporting. If you do even report, maybe, not full symptom relief. About 30% of non-responders achieved remission with a different antidepressant. Research comparing treatments for major depressive disorder, combining psychotherapy and antidepressant medication. We see that the odds might be increased of recovery, 10 to 20%. Obviously, medications are going to be quicker. Therapy might be longer lasting effects. You're working with a therapist. Perhaps they are monitoring changes or mood or changes to mood, what have you. So if we have someone who knows us and knows sort of what the depression looks like, or they've heard of our manic symptoms, they're saying, yeah, you came off that dose, you came down on that dose of medication. What you have reported to me right now seems as though, appears to be, could it be because we've come down on the Lamictal, mood stabilizer, and you're having a little increase of mania? Okay. So that's that hand in hand of pharmacological intervention and therapy intervention. Later studies, not that long ago, 6 years ago, it was noted that CBT as effective as medication for severe depression. Okay. Kind of blows my mind. I'm thinking, this is effective as medication. That is based on the individuals that did the entire trial and then gave reports. CBT is more effective than medication at preventing relapse. How come? I can't see anybody, so just feel free to talk.
I know one of the things that, as I was looking at this slide, I think, well, one of the things I think about is, as I was listening to The Body Keeps the Score and what Bessel van der Kolk believes and the studies that he was relating to, was so many times the medication is not effective without having a therapeutic involvement with a therapist, and that CBT provides us with alternative behaviors that affect our depression, if you will. So
yeah. Thank you. So I hope.
let's hope.
Okay, there we go. Can't see anybody. I'm going off voice. Thank you. So medication for bipolar disorder Lithium, that's been around a lot longer. Up to 80% receive at least some relief with this mood stabilizer. Potential side effects, serious side effects. Lithium toxicity. Toxicity. I just butchered that. But we're measuring kidney function. And so when you're on lithium, you are going to be monitored for your overall kidney function just to make sure that any increase or decrease isn't having a profound effect on or a toxic effect on different, I want to say it's kidneys. Newer mood stabilizers, Depakote and Zyprexa. I don't know tons about these. Again, I couldn't even tell you a side effect over one or the other, or how far we go on Depakote, that it doesn't work until we do lithium, kind of a next level. Learning more and more about those. Typically, that's when we consult with the psychiatrist of, okay, we were Depakote, it's not working as well, but did we max out on it? Sometimes the doctors are like, I don't want to max out on it. And just the symptoms keep going and not get any relief, because we could have that helpless hopelessness feeling that could increase suicidal ideation. Again, it says here both have side effects, serious side effects, and I don't know what those are, but again, an individual being educated by their prescribing physician helps a lot. When we say, what did that physician say or psychiatrist say? We're going to be the side effects that might be more severe than others, so we can watch out for them. They didn't say anything. Okay, let's not going to go on a Google fact-finding mission. I mean, you can find a lot of information, but advocate for yourself, and I think maybe, call back, get more information. Okay. Pharmacotherapy, monitoring and clinical concerns, drug to drug interaction. Those two drugs get together, what could be the outcome? Okay. And again, looking at all of these different factors, but just overall monitoring. Obviously, we see that there's lab monitoring, but we're also see a physical exam, which is going to let us know, looking at the vital signs, height and weight, body mass index. I leave this into the hands of the physician to be measuring that. Obviously, we're not measuring that. So, I've gained a rapid amount of weight, it went up in my BMI. Talk with your physician about that. We're not going to eyeball anybody and say, looks like your BMI went up, right? If someone shares that and they have major concerns over it, especially if it's a rapid amount of changes, then you're concerned, call your doctor. Let them know about that, okay? And tell them your concerns. The pharmacotherapy, going back to those, the toxicity signs, dizziness, the clumsiness, coarse tremors, vomiting. I was saying we were looking at toxic kidneys, so this definitely looks a little bit different when it comes to just reaction. The vomiting, confusion, blurred vision. So the common side effects, again, this is where we lean on the prescribing physician to be listing all of these, monitoring. If we're vomiting, we can get, what can we get? Dehydrated. Again, looking at the blood levels, 4 to 5 days after the dosage change. And then if we are just staying on this dosage, I'm checking every 3 to 6 months. That could be just the policy of the prescribing physician. That could be to get insurance to cover a refill of medication. Yep, 300 milligrams, looking at it every 6 months, still working. Let's approve another however many months of that. Antidepressants. So those SSRIs may be helpful for bipolar depression. Okay. So, used in combination with the mood stabilizer. So the mood stabilizer is helping with the mania. But we're still having the depression. We might do the mood stabilizer and an SSRI. If we add the SSRI, we're looking for any type of rapid cycling, switching from manic to hypomania. Then again, we see side effects. Okay, we've got the 200 milligrams of Lamictal. We have introduced 30 milligrams of Prozac. 2 weeks in it. Again, we looked at 2 to 3 weeks. So it works immediately on the neurotransmitters, but then we see how it works or not works with just increased agitation, maybe suicidal ideation, and at risk of serotonin syndrome. This is really complex, the serotonin syndrome. Too much serotonin into the body. Again, having one of my clients said she was having like the chills, vomiting a lot. The hard part was it was helping relieve the symptoms of depression, but if you're vomiting, a physical effect that can be depressing. So oftentimes we hit it with slow. Okay, we hit it with low and we go slow. So that might be starting at 5 milligrams, depending on the medication, or 10 milligrams. So just increasing it little by little in order to ensure that the reactivity does not cause harmful behaviors, side effects, etc. Supportive psychotherapy necessary. We've talked about this. We're reinforcing adherence to treatment. Okay. We're helping manage those comorbid conditions. Again, we don't know how alcohol affects every brain. We know research says it could be a depressant. A lot of times the labels of a drug, we caution you from drinking alcohol. It might mean that one drink feels like 3. It might be that it is contraindicated to symptom relief. And so that's one where I'm not like, well, don't drink, but I'll just still say it says not to drink. And my doctor kind of cautioned me, but I got this big party this weekend. I'll just say, okay, like what did your doctor say about could happen with drinks? Is it like it maximizes it? Again, if you have 2 drinks and it feels like 4, it could increase perhaps like blacking out, which could increase like a risk to yourself or drinking and driving. So just kind of that specific, very specific type of treatment. And a lot of it is the psychoeducation and working on coping skills as we maybe get back to work. Maybe we don't have as much help co-parenting. Okay. Someone was helping you and that person needs to go back to work. You're back on your own. We need to put in some coping strategies. You might feel okay, or you do feel better. You report feeling better. But if you're full-time watching 3 or 4 kids, we got to learn ways to cope should we start to feel overwhelmed, tired, and irritable. Those are just some examples. Child and family focused CBT. Again, we've known, we've heard all about this probably. Reward-based CBT with interpersonal psychotherapy. I don't know too much about how this works. Anybody know about reward-based CBT? Feel free to shout it out. That's okay. We can look it up. Gives us the acronym for a key component. Sorry, I'm chewing. Rainbow. A routine. Okay. We can count on getting up, going for a 10-minute walk. Been looking at, affect regulation, kind of monitoring that. Feeling that you can do it. Okay. No negative thoughts and live in the now. I don't really know about that. I think those kind of can come up every now and then, but watching how they're affecting mood, behavior, irritability. So yeah, you may have a negative thought, CBT, you've been doing it, but 2 weeks later, you've been working it, no negative thoughts, life is going well. Just because you had a negative thought, like I tell people, this does not mean it's not working. Maybe you had a hard conversation with your spouse and it left you feeling worthless. Okay. That doesn't feel good. Okay. Sometimes I'll challenge people like, oh, I had a conversation with my boss. They seemed a little angry, but they didn't say they were angry. Like, I feel, oh gosh, I'm the worst employee. Well, that's kind of inconclusive. Maybe consider just today we can't meet with the boss. Could you schedule a meeting? Balanced lifestyle as much as we can. Oh, how can we solve the problem? And then what are the varying ways we can get support? Is that with a friend, going walking once a week? Like what interventions in the way of support can we have? Cultural perspectives, a shortage of non-English scientific literature. So is there a translation, right? We don't have the words to go with symptom relief, depressive disorder. There's a shortage, so it can be hard to explain and therefore show effectiveness. Diagnosis in childhood could be difficult for many reasons, especially if we don't treat it. A persistent non-episodic manic symptoms, ultra rapid mood cycling, and then the bipolar diagnosis in the preschool age is controversial. That's that like preschool would be like under the age of 6 or 5. So be monitoring those symptoms. We might not give them a bipolar, diagnosis, but just be kind of monitoring it. How we express episodes of mania could look different in different cultures. Non-traditional treatment approaches for bipolar disorder. Maybe it is, I'm thinking of like acupuncture. Maybe it is like Reiki, lots of different alternative approaches that might be considered non-traditional, but who's calling it non-traditional, right? That's kind of a subjective label of non-traditional. It can be very traditional for that culture, country, race, ethnicity, religion. Really, we're looking at, is it working? Okay, we've done a great job of going to acupuncture. We know what we're identifying. Might not be working as well. We're overall looking from symptom relief from the treatment approach. Suicidality, okay. Key terms. Okay, so again, ideation, a thought of wanting to die by suicide, an attempt, the behavior, and a means to die by suicide. Suicide completion. We have completed leaving this earth from deliberate self-harm, self-injury. So it's final. Non-suicidal self-injury. We talked about this, I can't remember, but we are be, as clinicians, that we have that cutting is not the intention to die by suicide. The intent is not to die by suicide. For someone that is like, you might cut an artery, or you trying to, change the blood, whatever it is, that could seem very confusing because you are harming oneself. But sometimes not sometimes, oftentimes we're classifying as non-suicidal injury of the self. Epidemiology, suicide and suicidal attempts. Again, not going to read all of these, but the rate increases, the older we get, the highest rates in suicide for the US are white males over the age of 50. We know that the rates of suicide is increasing pretty dramatically in the United States, just at risk, of increasing suicide, being widowed, elevates the suicide risk or fivefold, okay, 4 to 5 times more. Can't imagine being without this person, okay? Guns, okay, are by far the most common means of suicide in the United States. Men are more likely to use a gun, hang themselves, so kind of a more sometimes classified as like a violent attempt. Women are more likely to use pills. You can die quicker and more and seamless. That sounds icky. Than pills. Okay. You don't take enough of the pills, you might not stop your heart or what have you. Take more, absolutely increase in it. But typically, individuals who use a gun or other means such as hanging oneself is going to have a higher outcome of completion. Okay. Again, we have all sorts of, we all feel differently about guns. I've heard a lot of, we have a lot around just making them harder to obtain for anybody. And again, harder to obtain for someone who is severely and persistently mentally ill or has had an attempt. Number one profession to die by suicide is veterinarians. Does anybody know why? Veterinarians.
Do they have access to like the stuff to kill themselves?
That's a good point. Sure, but not.
They could kill a bunch of animals all the time to like, God, that's gotta be pretty depressing.
I
Yes.
think I saw somewhere that like it's because of the owner. A lot of owners don't stay when their pets are euthanized, and so like they have to take on that like death and grief almost by themselves.
Yep.
They work really long hours too. I know Susie does a lot of work. She's in our program and does a lot of work for prevention of suicide of vets because she works with she is a vet or was a vet tech.
Okay. Yeah. So those long hours, if you've known the family for 9 years, you've known Scruffy for 9 years, and Scruffy means a lot to the family. And there's lots of interventions we can try for Scruffy, who is not well. Those tests can cost a lot of money. If you can't afford the test and the dog, Scruffy, what have you, gets sicker, often the most affordable pain alleviation would be euthanization of the animal. So you're, most likely if you're working in a vet's office, you're around animals all the time. You have maybe, you like animals, you like working with animals, you love Scruffy, you love this family, you're breaking this family's heart. You can't bend on the price. So we have a death of what can sometimes feel like a loved one and a disappointed family. So that overall like money situation, that's how veterinarians are increasing in debt. They cannot necessarily afford to give a break for using the scanner. The scanner's got to get paid for. Well, we're reducing the cost over and over. We've accrued more debt. So the first time I ever heard that, I was like, wait, what? You get to work with animals? Well, yes, you do, but those animals, oftentimes if there's no solution, the thought of the only solution being euthanasia, is pretty depressing. Annual deaths due to suicide per 100,000 people. So here we have gender specific and then the age group. As you can see here, we increase in age. We have a increase for males as we go up the age group. We, for women, increase at the highest between the ages of 45 and 64. After the age of 65, we go down a bit for women and go up for men. Why do we think that is? Why in that 65 plus are we way up here for men with completion of suicide versus women?
A lot of men tend to lose their wives around that age and find it difficult to connect with other like men or even just people their age in general, whereas women tend to, if their spouse passes, find community in other women and support in that way, and are more likely to seek services for help for depression or anxiety or things like that.
Mhm.